Hi friends, I welcome you all for this session. Today we are going to see some of the important signs that we see in fetal echocardiography in the case of transmission of great arteries. We all know about the fetal circulation and the preferential diversion of the oxygenated blood from the umbilical vein into the ductus venosus and to the foramen ovale to the left atrium. And the two shunts which are in the fetal heart is foramen ovale and ductus arteriosus. Now in the case of d-TGA, the right ventricle is connected to the aorta and the left ventricle is connected to the pulmonary artery. There is no significant clinical manifestation in case of d-TGA in fetus due to the presence of these two shunts which are foramen ovale and the ductus arteriosus. What happens when the foramen ovale and the ductus arteriosus closes in the postnatal period? It becomes two separate circuits which runs parallelly. That is, the deoxygenated blood enters the right atrium, right ventricle, and this deoxygenated blood again flows through the aorta into different organs and then return back to the right atrium without getting oxygenated. Also, the blood from the left atrium to left ventricle goes through the lungs, gets oxygenated and returns via the pulmonary veins again to the left atrium. So in the postnatal period, as soon as these two shunts closes, the baby will manifest with hypoxemia and cyanosis, and therefore this heart disease is a duct dependent lesion. Now let's see the typical morphological characteristic of d-TGA. There is normal atrioventricular concordance, but however there is discordance in the ventricular-arterial connection. Due to this, the normal curvature of the interventricular septum is altered. Therefore, in d-TGA, the outflow tracts does not cross, whereas they arise out of the ventricle in a parallel arrangement. The aortic valve is positioned anteriorly and to the right of the pulmonary valve, and that is why it is called d-TGA, because the aortic valve is to the right of the pulmonary valve. Whereas in the case of corrected TGA, the aortic valve is to the left of the pulmonary valve. It can be seen clearly in the picture that is shown as modified Van Broek diagram. Now let's come to our diagnostic feature by ultrasound. The four-chamber is generally normal, and that is why even the recent studies says that the rate of detection of d-TGA is up to 50%. Because this gets missed if only four-chamber is included in the protocol of cardiac screening. But the detection rate increases from 50 to 80% if the outflow tract visualization is included in the cardiac screening. Now coming to the five-chamber view, the outflow tract that arises from the left ventricle appears short and bifurcates early as soon as it comes out of the left ventricle. So this is a clue that it could be a pulmonary artery. Also, when you come up cranially and go to the three-vessel trachea view, we can see only two vessels instead of three vessels. Although there are multiple differential diagnoses for seeing two vessels in three-vessel trachea view, when you turn this probe longitudinally to see the outflow tracts, you can see that the great arteries does not cross each other, whereas they are in parallel arrangement. And you can see that the aorta arises from the ventricle, which is in the anterior portion. We will see about this in detail in the upcoming slides. There are two types of TGA. One is simple or isolated TGA, which is common and seen in up to 60% of the cases. The next one is complex TGA, which is associated with other anomalies and is seen in up to 40% of the cases. Out of this, the most commonest associated anomaly is VSD, which is seen in up to 30% of the cases. Next comes pulmonary stenosis, which is seen in up to 15% of the cases. It can also be associated with aortic coarctation in up to 5% of the cases. The other common anomaly is coronary artery anomaly. In d-TGA cases, the coronary artery anomalies can be associated in up to 30% of the cases. The other associated anomalies are right aortic arch and anomalous venous connections, including both systemic and pulmonary venous connections. The risk of chromosomal abnormality and extracardiac abnormalities are relatively less common when compared with other congenital heart disease. It occurs frequently in women with overt diabetes and history of exposure to pesticides and history of retinoic acid usage. Now we are going to see the various signs that have been described to increase the detection of. We know that one of the characteristic feature of identifying great vessels in fetal echocardiography is by looking at the bifurcation. Any vessel that show bifurcation is generally perceived to be pulmonary artery. And usually this is the first clue. So having that in mind, now if you look at the outflow tract that is arising from the left ventricle, you can see that it is bifurcating, and what is described here is bird's beak sign. If you see in the lower picture, it is drawn in the white line. This bird beak sign is formed because of the sharp angle made by the left branch of pulmonary artery with the main pulmonary artery and ductus arteriosus. So to repeat, the bird's beak sign is nothing but the sharp angle made by the left pulmonary artery with the main pulmonary artery. This gives the appearance of bird's beak. Also, not only the bifurcation alone confirms that it is pulmonary artery, we have to trace where these branches reach up to, on which organ it supplies, and then also the pulse wave Doppler can help us in differentiating the pattern between the great vessels. The bird's beak sign that we saw in the previous slide is easy to diagnose because it involves only two-dimensional echocardiography. Now coming to this sign of big-eyed frog sign, or named as Keropi sign, which is a cartoon character. This can be diagnosed only by doing stick. So it may not be feasible for everyone, but one who is used to do the stick can identify this sign as one of the clue for suspecting transposition of great artery. If you see the picture in the middle of the multiframe that is displayed in the right side, you can see that it looks like aorta and pulmonary artery looks like two eyes of a big frog, like depicted in the corner of the slide. If you see the stick image on the left side, it will show you the normal arrangement of pulmonary artery, which is to the left side and it is anterior, followed by the aorta, which is slightly to the right and posterior to the pulmonary artery. This is the normal arrangement in a normal fetal echocardiography. Now if you see the image on the right side, we can see that both the great vessels are in side to side arrangement. This is also one of the clue. Now coming to this next sign, which is called as mesonomer 3 vessels. Normally we have ductal arch, aortic arch and SVC in 3 vessel trachea view. Whereas in the case of d-TGA, we see only one arch in 3 vessel trachea view, and this arch is the aortic arch. If we move down slightly caudally, we can come across the ductal arch. If the probe is rotated 90 degrees, then we can see the parallel outflow tracts as seen here, with the outflow tract arising from the ventricle. Figure 1 shows the normal pass view of fetal heart. Here you can see the pulmonary artery arising from the most anterior right ventricle. The convexity formed by the curvature of the pulmonary artery is towards the left side. Now figure 3 shows the 3 vessel trachea view in case of d-TGA, where you can see the aorta arising from the anterior right ventricle, but the side of convexity of this aorta is towards the right side. So to compare both, in figure 2 we can see normal 3 vessel trachea view and also 3 vessel trachea view in d-TGA. When you observe the convexity of the curvature of the pulmonary artery in normal fetus, it is towards the left, whereas the convexity of the curvature of the aorta in d-TGA, it is towards the right. This sign is very useful, especially in the case of first trimester, where we will be able to see only one vessel in 3 vessel trachea view and we may not know which vessel it is, and there this sign comes as an important clue to suspect d-TGA. This eye sign is nothing much different from what we have seen already. We know that in 3 vessel trachea view we see only one vessel, that is the aorta. We know that the right ventricle is the anterior ventricle, and in case of d-TGA we know that the aorta arises from this right ventricle. So this aorta takes a long course from the anterior-most ventricle to reach to the left side of the spine to form the descending aorta, and this long course of aorta forms what is called as eye sign. To remember, this is not exclusive to d-TGA. It is also seen in cases where you see a single vessel in the 3 vessel trachea view. Now having diagnosed d-TGA, the next step would be to go for the management, where it is probably better to advise for QF, PCR and microarray, and if required exome sequencing when associated with other congenital anomalies. Although we have seen that the risk of chromosomal abnormalities and associated congenital abnormalities with TGA is rare when compared to the other congenital heart disease. Also, we need to serially follow up to look for the size of foramen ovale and patency of ductus arteriosus, the details of which I will discuss in subsequent slides. And it is also necessary that we should do detailed neurosonography. In case of simple TGA where it is not associated with other cardiac abnormalities, the surgery in the postnatal period would be arterial switch operation, which have a relatively good prognosis of up to 95% of long-term survival. Now, what happens in this surgery is the aorta and pulmonary artery are cut off above the level of the valve. This is to avoid damage to the semilunar valves. Now the arteries are switched. Important step here is to transfer the coronary arteries to the neo-aorta that we have created. The common long-term abnormalities that we can come across can be like pulmonary stenosis in the neopulmonary artery that we have created, and maybe neo-aortic root dilatation or aortic valve regurgitation. The arterial switch surgery that we saw in the previous slide applies to cases of simple d-TGA. Surgery becomes more complicated when there is abnormality in the origin of coronary arteries. When there is outflow tract abnormalities like aortic stenosis or pulmonary stenosis, then the simple arterial switch surgery cannot be done for these conditions, and it is going to be a little bit more complicated surgery than this. So whenever we diagnose d-TGA, the things that we should look for is whether it is associated with other cardiac abnormalities like VSD, or is there any obstruction in the outflow tracts, and how is the patency of foramen ovale and ductus arteriosus. The association of VSD or the outflow tract narrowing can decide the type of surgery that can be planned in the postnatal period, but the patency of ductus arteriosus and the foramen ovale will determine how early you need to perform the balloon atrial septostomy in these cases. To remind, as discussed earlier, the patency of foramen ovale and ductus arteriosus is mandatory to maintain oxygenation in the postnatal period. So these fetuses with duct-dependent lesion has to be delivered in tertiary cardiac care center, and the patency of the ductus has to be maintained by prostaglandin infusion. In cases of early closure of foramen ovale or restricted foramen ovale, there may be a requirement for balloon atrial septostomy. The intention behind these two procedures is to maintain the shunt between the right and the left side to prevent hypoxemia. To remember, there are two congenital heart disease. One is HLHS and another one is d-TGA, where in the intrauterine life also the brain receives relatively less oxygenated blood. The recent studies have come up with the possibility of white matter injury in these two cases.